Good morning, everybody. Today we are giving the lecture of Comitant strabismus. There are two main types of strabismus. The comitant type, which is the subject of the lecture today. In comitant strabismus, the deviation is the same in all directions of gaze. The other type is the incomitant type or the paralytic type, where the deviation is more in the direction of action of the weak muscle. That is, the deviation is variable. The mechanism of how to have the two eyes parallel in all directions is dependent on some mechanisms. Afferent pathway, the afferent pathway, that is the impulses coming from the image of the two eyes, if the image coming from the two eyes are of similar shape and size, same clarity and same focus, this will be understood by the central mechanism or the fusion center. In the fusion center of the brain, there will be a fusion of the two images coming from the two eyes. Then, to preserve this one image or to have the image preserved as one image with no diplopia, there are impulses going to the extraocular muscles through the efferent system to preserve ocular alignment, to maintain parallelism of the eye, to maintain bifoveal fixation and fusion, and in this case, no diplopia. Now we go to the etiology of comitant squint. What can happen to have some patients squinting? There are mechanical factors as muscular, bony, or fascia, neurogenic factors or motor factor, including an abnormal accommodation. This is very important. How abnormal accommodation can cause comitant squint? Abnormal accommodation means uncorrected hypermetropia. In some cases, this is very important. In hypermetropia, if it is uncorrected, the patient will have to exert accommodation to bring the image from behind the retina toward the retina. And this abnormal accommodation, which is exerted for far vision contrary to the normal, will be accompanied by abnormal convergence, because normally every 1 diopter of accommodation exerted is accompanied by 1 meter angle of convergence. Normally, we don't accommodate for far vision, we accommodate only for near, but uncorrected hypermetropia, they will accommodate even for far vision. The second important cause is abnormal convergence. How abnormal convergence can cause strabismus? There is a special ratio known as the AC/A ratio. That is the accommodative convergence to the accommodation ratio. This is, as we said, every 1 meter angle of convergence is accompanied by 1 diopter of accommodation. But in some patients, they have an abnormally high AC/A ratio, leading to abnormal convergence and more convergence and convergence squint or esotropia. Sensory causes include afferent obstacle, or as in weak vision in one eye, and also weakness in the fusion center of the brain. Also, we have to remember that there are hereditary factors. Now, the comitant squint is divided also in two main types. The latent type or heterophoria, in which type the eyes are kept aligned, but we can detect this type by special tests to diagnose it. The other type is the manifest type or the heterotropia, where the eyes are deviated from the start and it is easy to detect them just by simple examination. The characteristics of comitant squint: the angle of deviation is constant in all directions of gaze, and this is different than paralytic squint, where the angle of deviation is variable in different directions of gaze and maximum when looking in the direction of action of the paralyzed muscle. Also, ocular movements are normal, the adduction movement and diversion movement, while in paralytic squint or in comitant squint, the ocular movements are defective. There is defect of movement in the direction of action of the paralyzed muscle. Also, of the characteristics of comitant squint, that there is no diplopia. No diplopia, while in paralytic squint there is diplopia, as we said before. No diplopia. Why? This is not a good sign, because no diplopia because of adaptive mechanisms, either suppression, the image coming from the deviated eye is suppressed to overcome the diplopia. If the squint is alternating, the suppression is also alternating and there is no fear of it. But if there is strabismus or squint always in one eye all the time, there is continuous suppression of the image of this eye, leading to the more serious adaptive mechanism, which is amblyopia or lazy eye. Also, there might be abnormal retinal correspondence. What is this abnormal retinal correspondence? This means that an extrafoveal point of the squinting eye is corresponding and acting with the fovea of the normal eye, because the normal retinal correspondence means that the fovea of the right eye is seeing at the same time of the fovea of the left eye, and the image falling on the right retina is corresponding to the image falling of the right temporal retina is corresponding to the left nasal retina, and so on. Here, extrafoveal point is of the squinting eye is corresponding with to the foveal point of the normal eye, and this is something considered as a complication. Now we come to the classifications of comitant squint. Many classifications, and we'll tell what are the more important. The fusion state. According to fusion, the strabismus is divided into latent type, intermittent, and constant. According to the direction of deviation, and this is the classification that we can see in most of the books. According to direction of deviation, it might be esotropia, that is deviation in, exotropia, deviation out, hypertropia, deviation up, cyclotropia, that is rotation, intorsion of one eye or extorsion. According to fixation, the strabismus might be unilateral, which is the bad type, and might be alternating, where no amblyopia in this type. Also, according to accommodation and relation to accommodation, might be accommodative type, fully corrected when accommodation is cured, excessive accommodation, by wearing the glasses. Partially accommodative, that is the strabismus, partially corrected by glasses and still residual angle. And non-accommodative type, that is having no relation to accommodation. According to the onset, it might be congenital type, appearing within the first 6 months of life, or infantile type, appearing later on. Now, esotropia or convergent squint In literatures before it appeared, it was detected 3 times more than exotropia. But now, more and more of literature are speaking about the exotropia, constant type, intermittent type, so these numbers can be changeable. The types of esotropia, the more common are the congenital type and the accommodative type. Less common are the sensory, due to weak vision in one eye, and this can be detected even in any age. And consecutive type means overcorrection of exotropia and postoperative leading to esotropia due to overcorrection, operating on more muscles. Now, the congenital esotropia, which is the type appearing within the first 6 months of life. Like this photo. They have some characteristics. Angle is big, as we see, 40 prism or more. The incidence of congenital esotropia is roughly 1% of most series and is more common in children who have neurologic disorders as some of the syndromes and anomalies in the central nervous system. Also, sex and race distribution are equal, no sex predilection. Here is a photo of a child having congenital esotropia. See, here the angle is big, here the right eye is squinting, and here the left eye is squinting. This is alternating type of congenital esotropia. Note that the angle is very big. The clinical presentation, we have large constant esotropia, usually more than 40 prism diopter. The onset is from birth to 6 months of age. Amblyopia is common because it occurred in the critical period of development of the macula. Patients may cross-fixate. If there is cross-fixation, what is the meaning of cross-fixation? Meaning that the child, when looking to the left, he is looking with the right eye, which is converging, and he can look to object on his right side by the left eye when it is converging. So he is using both eyes. If the child is having cross-fixation and is using both eyes, in this case, we know that there is most probably no amblyopia, except if there is some preference. He might have cross-fixation, but one eye is preferred more than the other. This means that the less preferred eye or the less dominant eye might have amblyopia. Look to this video. This child is having cross-fixation and all the time turning his head to the right and to the left. Large angle esotropia, looking with the right eye to objects on his left side and turning to the right to look to objects on his right side by the left eye. There is cross-fixation and the head is turned all the time. The refractive errors of these cases tend to be similar to those of normal children of the same age. Also, might be associated motor phenomena, usually present after 1 year of age. These abnormal motor phenomena include either inferior oblique overaction, dissociated vertical deviation, or latent nystagmus. The inferior oblique overaction is noted in about 70 to 70% of patients, mostly occurring during the second year of life. It can be unilateral or bilateral. And also there is an important thing to note that early surgical correction of esotropia has nothing to do to decrease the incidence of inferior oblique overaction, which might appear later on. So if we operate a patient from congenital esotropia in young age, we have to tell the parents that he might develop an inferior oblique overaction or a vertical type of squint, and this is not related to the operation performed in this early age. Left inferior oblique overaction, here noticed in the left eye. In adduction, to detect it, we have to make the eye adduct or look to this direction. Right eye, in adduction, no overaction of the inferior oblique. Look here, no adduction, no hypertropia in adduction in the right eye, but there is hypertropia in adduction of the left eye, left inferior oblique overaction. Here also, patient normal in the primary position, operated before in young age from congenital esotropia, and the horizontally no esotropia in the primary position, but vertically there is abnormal here inferior oblique overaction of the left eye, detected in adducting the left eye by looking to the right, and also inferior oblique overaction of the right eye detected when looking to the left by adducting the right eye. Hypertropia in adduction, more in the right than the left. No problem, because this could be put in mind when correcting it by graded recession of the inferior oblique muscle. The dissociated vertical deviation, also it can be occurring in about 70 to 70% of patients, and it is has nothing to do with operating the congenital esotropia in young age. Here is the video. Look to the right eye. During periods of visual inattention, there is hypertropia of the right eye, and then returning without hypertropia of the other eye. Nystagmus. Latent nystagmus can occur either in the rotatory form or in a horizontal form. The horizontal latent nystagmus with a rapid phase toward the unoccluded eye also is present in about 50% of patients of congenital esotropia. How to detect it? Look to these patients, corrected by his glasses. After we occlude one eye, there is nystagmus occurring in the unoccluded eye. Look, nystagmus with a rapid phase toward this unoccluded eye. When we occlude the left eye, the same appears in the right eye. Here, nystagmus, latent nystagmus appearing only when we occlude one eye, with the rapid phase toward the unoccluded eye. What is the problem here? The problem is if we do occlusion for amblyopia, the nystagmus will appear, so we couldn't do occlusion in these cases. The differential diagnosis of congenital esotropia, first of all, is the pseudo-strabismus, because many of the cases referred to the ophthalmologist by the pediatrician for suspicious congenital esotropia are cases with wide nasal bridge and pseudo-strabismus. In this case, like this one, the corneal reflex or the Hirschberg test is normal corneal reflex in both eyes in same position, and here there is wide nasal bridge, and if we want to show to the parents this about the cases referred from the pediatrician, not all of them are congenital esotropia, but to be on the safe side, we have to examine all of them, all the suspicious cases, And if the light reflex is in the same position, this demonstrates good alignment, and also to demonstrate to the parents that there is no squint, we elevate the skin, pinch the skin over the nose, and to elevate the nasal bridge away from the face. The two eyes will appear normal, and the parents will be convinced that there is no squint and this is only pseudo-strabismus. How to evaluate the patients preoperative? We have to evaluate them to do the deduction test movement of one eye in all directions, adduction, major rectus, abduction by the lateral rectus, up and in inferior oblique, up, down and in superior oblique, up and out superior rectus, down and out the inferior rectus. And also the version movement, which are the binocular movement of the two eyes together to compare inferior oblique overaction or V pattern. Anything needs comparison, need version movements. We have to detect amblyopia, check fixation preference. If there is cross fixation, this indicates that no significant amblyopia. We have to treat amblyopia first before treating squint by patching the dominant eye a certain period of time until the squint, which is unilateral, is transformed into alternating type. The transformation of the unilateral squint into alternating type means that the vision now is equalized in both eyes and the amblyopia is cured. We have to measure the deviation by prism and alternate cover tests or Krimsky test for verification of far and for near, and this you will study and you will see in the lecture of how to examine a case of squint in the practical round. Also, we have to know the cycloplegic refraction to test the refraction under complete cycloplegia using cyclopentolate. If the refraction is 3 diopters at least or more than 3, we can prescribe the full hyperopic correction, and this is at most. And this is the first thing to do, to correct the error of refraction. If after correcting the error of refraction, still an esotropia is present of 10 to 15 prism diopter at least, we have to resort and go to surgery in these cases. What is the surgical approach for congenital esotropia? The procedure of choice in these cases is bilateral major rectus muscle recession using the near deviation at the target angle. In older patients with the irreversible amblyopia and one eye is always weak and always deviated, we operate on this eye by recessing the major rectus and resecting the lateral rectus muscle. Here is how to do muscle recession. First of all, we do conjunctival incision, exposing the muscle, the major rectus here, and taking sutures just near to the insertion. After taking the sutures here and securing the muscle very well, to be very well secured, not to slip, then we detach the muscle from its insertion, but taking care not to cut the sutures. Then we measure the amount of the deviation by the compass here to be perpendicular from the upper edge and from the lower edge of the tendon, original tendon of insertion, and to take the sutures here, the new suture or new insertion intrascleral, but taking care not to perforate the sclera, because here the sclera is the thinnest in all the globe. under the insertion of the recti muscles, and we use a spatulated needle. You want to take 5? No, after the lecture. Now, accommodative esotropia. Accommodative esotropia means esotropia which is fully corrected by inhibition of accommodation, like this patient. She is having high hypermetropia, and we see if she is not wearing the glasses, she is esotropic by the corneal reflex here, and after wearing the full correction, she is totally corrected, eyes are parallel here. No operation is required, or even the operation is contraindicated. Also, this one, accommodative esotropia, fully corrected by glasses, and operation is contraindicated. The only treatment is to wear the glasses all of the time. Here in this child, partially accommodative esotropia, she was hypermetropic and only partially corrected by glasses. And here in the operating room, the total angle without using any glasses. Here alternating right esotropia, left esotropia. And the target angle was the residual angle, the angle not corrected by glasses. And here after surgery and after wearing the glasses, the surgery done in this case was bilateral medial rectus muscle recession. Here is non-accommodative esotropia. Non-accommodative, look to her nice blue eyes. She was having neglected esotropia since childhood, and she came when she was about 23 years or more with this alternating type of esotropia. Of course, no amblyopia, and this is the eyes after medial rectus recession of the two eyes, the two sides. Still small residual angle, but she was operated after this by resection of the lateral rectus of the left eye. The accommodative esotropia, so, is a convergent type of squint that can be corrected, as we saw, by inhibition of accommodation. How to inhibit the accommodation, the unnecessary accommodation exerted for far, by wearing the glasses or even by cycloplegics in smaller children. The cause is uncorrected hypermetropia. It occurs at the age where accommodation started to be used, so at the school age from 2 to 5 years, not in childhood. The deviation is variable, more at near amblyopia. Can occur in unilateral cases, but in alternating cases, no amblyopia. So in unilateral cases where amblyopia is present, we have to treat amblyopia first by occluding the normal fixating eye, part-time occlusion, and following until the unilateral squint is transformed into alternating type. The treatment of accommodative esotropia include 4 items: glasses, occlusion, exercise, and surgery. Glasses means full correction of hypermetropia by we are doing complete cycloplegia by atropine or cyclopentolate. Now all the cases are detected or examined by cyclopentolate eye drops to detect the full cycloplegic refraction and give it in constant use of glasses. Atropine was used before. Occlusion therapy if there is amblyopia. We have to cover the strong eye to force the child to use the weak eye, and if there is unilateral squint, this means that there is amblyopia. Alternating squint means no amblyopia. Orthoptic training means the use of the two eyes together to exercise them to strengthen the fusion amplitude and to get rid of diplopia and to be aware of any suppression. All these could be done by the synoptophore. The synoptophore is used to examine and to exercise. Surgery is done in only cases when needed. That is, if the squint is fully corrected with glasses as the photos we saw before, operation is contraindicated and the only treatment is to wear the glasses all the time, with follow-up to change the refraction and change the glasses when needed. If the squint is partially or not corrected with glasses, operation here is indicated. What type of operation? We have to weaken the action of the medial rectus by recession or to strengthen the action of the lateral rectus by resection. Okay, this is well understood. So we can now go to exotropia. Any questions we leave at the end. After the lecture we can discuss and answer any questions. Exotropia means deviations of the eye out. Here is left exotropia, and this is after surgery of strengthening the medial rectus or weakening of the lateral rectus. Here also right exotropia, and here post-operative after operating two muscles in this same eye, resecting the medial rectus to strengthen it and recessing the lateral rectus to weaken it. Also right exotropia. Note that all these patients are adult. Most of cases of exotropia constant type are coming in adulthood. So exotropia or divergent squint, there are many types, but here 5 types. Not like esotropia, which were these 4 types present in esotropia: congenital, accommodative, sensory or weak vision in one eye, and consecutive. Here we have an important and most common type, which is intermittent exotropia in about 50% of cases. The intermittent exotropia is having different grades, starting by exophoria. That is, when we cover one eye by semi-translucent cover so that the patient cannot see, but we can see the eye behind his cover, the cover where it is deviated. The eye is deviated behind this semi-translucent cover out, exophoria. And if we occlude his left eye by semi-translucent cover, he cannot see through the cover, but we can see his eye deviated out, also exophoria. After we remove the cover, the eyes return normal. This is the first grade or exophoria. So this intermittent exotropia starts in early childhood by being latent, like this patient we have seen. It is exophoria, then intermittent, and then becomes constant in older age. So it is usually progressive. The symptoms include asthenopia or eye strain, intermittent diplopia when the eye is deviating, and in children, suppression can occur, but amblyopia is rare. Suppression occurs in the periods when the eye is deviated, but since the angle is variable and the suppression occurs sometimes and sometimes the eyes are parallel, so amblyopia is rare in intermittent exotropia, and this is something good. This is a child with intermittent exotropia, grade 2, that is sometimes the eyes are parallel or most of the time, but after exhaustion and after eye strain sometime or during periods of visual inattention, one eye is deviated out, right exotropia, and return after sometimes spontaneously, and here without putting cover and without anything. the left eye sometimes deviate out, left exotropia. This is intermittent type of exotropia. How to treat intermittent exotropia? Also 4 items of treatment: glasses, occlusion, exercises, and surgery. Glasses. Here, the concept of giving the glasses is to make the child use his accommodation to correct the exotropia. So if the child is hypermetropic, we can leave him a little hypermetropia that is under correction of hypermetropia so that he can use his accommodation, and this is beneficial for him to correct the exotropia. And if the child is myopic, we give full correction of myopia to return him normal, to put the image of far vision on the retina so that he can use his accommodation for near. Occlusion, if there is amblyopia, we do occlusion of the normal eye to get rid and to cure the amblyopia. Orthoptic training by the synoptophore and by other tests and methods of exercising, anti-suppression exercises, and to increase the fusion amplitude. Surgery, always we have to correct before the development of suppression. We do weakening of the lateral rectus by recession or strengthening of the medial rectus by resection. How to do resection? We'll see it. In muscle resection, we decide the amount of the muscle to be resected and to be measured here. After measuring the amount of the muscle to be resected and this distance from the tendon of insertion toward the end to be resected, we take sutures in the bulk of the muscle with knot and to be secured, so not to be slit. And then we cut the muscle here in front of the sutures and cut it again here, the other part at the tendon of insertion, and this part is the resected part. Then the rest of the muscle here is secured and attached to the original tendon of insertion and tied so that the muscle is shortened and strengthened again here and tied here. This is the muscle resection to strengthen the muscle. In cases of exotropia, we strengthen the medial rectus. Here is an example of case of exotropia where in adult age, constant type, we recessed the lateral rectus and resected the medial rectus, and this is the postoperative appearance, well corrected. Here is a case of exotropia in an adult girl, neglected since long time and weak vision in this eye. We resected the medial rectus and recessed the lateral rectus, and this is the normal appearance in her post-operative period, and both are satisfied. In these cases, our aim in adult age is not to cure amblyopia because it will not be cured, only the cosmetic appearance. So in old age like this, only all what we have to do is to correct the appearance, and we can go to surgery from the start. And thank you very much for your kind attention.